came out on the 10th of February this year from the Institute of Medicine in the United States, where a very serious group of multidisciplinary scientists, clinicians, psychologists and others met to try and get to grips with the complexity around chronic fatigue syndrome and ME. And you'll be familiar with the report. It created a lot of publicity at the time, some good, some not so good, but it really did stimulate a debate. And I'm extracting from the report some of the features that really stood out for me personally as being, I think, a descriptor of what we're dealing with. So first of all, the fact that we're dealing with a serious debilitating condition affecting many people around the world, not just in the US of course, but in many countries around the world. Secondly, that the disability and impairment is substantial, and I think this is something that differentiates this condition from even many other chronic conditions that we encounter in modern society. And despite all the efforts that we all try to make, we don't have an effective mechanistic cause for any of these disorders, nor do we have a clearly defined way of diagnosing it with some simple test procedures. And this obviously makes identification complicated and difficult. Then healthcare providers have been sceptical about this condition, largely based on its historical perception. And this really is very troublesome to patients for obvious reasons. And I think it's this concept that this group of conditions are psychological or made up in the patient's minds that causes, I think, this terrible impasse with the health professions, which has been a lot of the cause of the problems over the years. And this really is because of a lack of our understanding of the nature of the processes that are involved in this illness. And then, of course, as a result of this, as reported in the US, but true in every country we look at, once diagnosed, patients often experience hostility from the healthcare professionals in terms of diagnosing and managing it. And this is a serious, serious issue, because this is what leads to the impasse that has happened between the professionals and the patients over the years previously. But I think things are changing, and this report, amongst several, I think are helping do that. Now, whether changing the description of a disease or not by words is an improvement, well, we can debate that endlessly. I don't think that's the issue, to be honest, because I think all of us realise we're not dealing here with a single disease entity, that we're dealing here with a complex mix of diseases that are expressing themselves through different causative mechanisms. But I think what this report did, and I've shown it in red really, is to crystallise the fact that this now is a well-recognised medical condition. Now, I know that others have said that in the past, but I think having that said by this influential body as part of the National Academy of Sciences in the United States is an important one. As I say, whether we use that as a description or not is up to you, but I don't think that is the main point. The point is that it is a medical condition. And one of the conclusions, of course, is that by defining it in terms of the way it presents, this report came out with an opportunity, I think, of refining the diagnosis and making it much more acceptable for practitioners to be able to use in the clinic. I'll come to that in a second. The criteria that they thought about a lot and distilled and tested will be shown in a few minutes. So, in essence, I think this organisation, and certainly the collaboratives since we've been involved together, joined up in this way, recognise very much where the Institute of Medicine was coming from, because I think this is our view too. And so we're not talking here off a different hymn sheet, we're on the same hymn sheet. So this is the description that the Institute of Medicine came up with. I won't read it out. It's very similar to other descriptions, but I think it's been slightly refined in some of the areas. But the nice thing about this, to me, is that it's an inclusive definition, an inclusive description. And that means that if we're going to explore this as a stratified disease with different disease components, then we have to think about it in terms of capturing the whole population rather than imposing on it our own descriptors of what we think may be going on in terms of categorizing patients into different subtypes. So anyway, we'll be discussing a lot of this during the meeting, different sections in there, and it'll be interesting to see at the end of this 2 days where we sit with all of this. It'll be fascinating to realise. So my interest really in trying to present to you a new vision comes from my involvement with the Medical Research Council and the Horizon 2020 programme in Europe on stratified or personalised medicine. And I had the privilege of co-authoring a report for the European Union on this. And I think the interest to me really was that for the very first time, medically and scientifically, as well as politically, we're putting the patient at the centre of all of this. And I think that's really so important in a disease which manifests in so many complex and difficult ways. You'll see the description of personalised medicine on the right. Again, this came out of the President of the United States Working Party on personalised medicine some 3 or 4 years ago now, and is now being implemented across Europe and the United States and in other countries. So, in response to this, the National Institute of Health, in their Pathways to Prevention programme, have recently reported the findings of where we go next with this, because it's nice having reports, nice knowing what we should be doing, but how are we going to do it? And so this was the description of this Pathways to Prevention report that was published earlier this month. Innovative biomedical research is urgently needed to identify risk and therapeutic targets and for translational efforts. I don't think any of us would disagree with that need. And that could have come out of the UK just as it's come out of the US. And they support large-scale efforts to find a suitable definition for the disease, including the relevant stakeholders. And I think the definition I've just put to you coming out of the Institute of Medicine is one such definition. Secondly, we've got to appreciate the methodological problems in past research. And a lot of this is around small study sizes, disagreements about inclusion and exclusion criteria, and little knowledge about what hard biological processes to grasp onto when trying to pick up some of the morbidity of this particular condition. And so they recommended that key populations must be included in this, including children, minorities, men, rural, and of course homebound residents where the condition is most severe. And then recent insights, and I've listed them here, I didn't look at them, we've got them in our poster sessions and on talks today and tomorrow, give one the confidence in a way that there is going to be a way through this. And I think that's the thing that really we've got to lean on now. But the methodology and the technology that we need to do it is going to be quite different from what we've used to using in the past. And the other thing that's important, and when the Medical Research Council initially put some money into this field 3 or 4 years ago now, it was to bring new voices in the field. So what we need to do in this area is to bring scientists and others who are not in our field, but who are experts in their fields, to come in and help us unpick the complexity of this group of conditions. So this is what the chairperson of this P2P group came up with. This is Carmen Green from Michigan. We need to learn more about the cellular molecular mechanisms. Right, that's why we're here. Secondly, we need to find more studies that can be reproduced and gain a better understanding how ME CFS affects people and their families in meaningful terms to them. We need to have a greater understanding of the impact of this condition across the life course, not just as an acute or relapsing condition. And we have to address knowledge gaps. And this is the bit that, of course, what the collaborative is all about, is addressing the knowledge gaps. And the panel is calling for more research, more opportunities for new investigators to invigorate the field. And that's really what we're hoping to do with this collaborative too. And you'll see it, the last recommendation here is collection of biological samples from well clinically and physiologically phenotyped patients for a biomarker discovery program. So, I put to you what I call the grand challenge in this area, which I think we're now heading towards. And the grand challenge is to agree a practical case definition, which I think we're almost there with all this work that's gone in the US and in this country and elsewhere. And then to deliver a pan-UK joined-up approach to subphenotype this group of conditions using modern statistical approaches applied to clinical and to physiological and routine pathological data. Thirdly, to collect the biological samples, which referred to in the previous thing, not only in terms of disease process, but exposures such as diet, chemical exposure, and so on, using modern technology to do this. And then to integrate this biological information to the different subphenotypes that are identified, and use pathway analysis to unpick the causal mechanisms, and then identify preventative and therapeutic targets. It sounds all very simple and straightforward, but of course it's not. It's very complicated and very challenging, but it is being done in other disease areas, and I think this gives us the confidence that we can do it here. And as I say, I'm from the world of asthma and allergy, so my application today will be that. But I could have put cancer up, diabetes, hypertension, obesity. I could put a number of things up, and I'm going to put asthma up, because asthma, everybody knows what asthma is. It's narrowing of the airways, you can see on the right there. And we all thought this was a homogeneous condition. And we have treatments that are targeted on the basis that it is a homogeneous condition. But it turns out that that's not the case. Some treatments work in some patients and others work in other patients, and it's in fact incredibly heterogeneous. And really using technology, one's been able to unpick this disease and identify novel therapeutic interventions. And this is what I've really just been talking about in terms of the pathway. This was a €42 million project that IMI funded in Europe, which is reported about 2 weeks ago at the European Respiratory Society Congress in Amsterdam. And it's just the process I've described that I think we need to do. And what's exciting about this, if you take this so-called homogeneous disease asthma and you apply this statistical approach and then start exploring using new technology, we have in fact 6 different types of asthma which are very far separated from each other using this what's called a topographical approach. And each one of those has different causative molecular and cellular pathways associated with it. So we've got one, as you'll see down in the left bottom here, where mast cells are heavily involved, as you see in red there, red and orange. Then, you know, if you gave those patients a mast cell inhibiting treatment, the likelihood is that you would get a therapeutic response. But if you gave that same treatment to some of these ones at the top, it wouldn't work at all. So the point about this is to identify the molecular and cellular pathways specific to the patient subgroups within this very complex area. Asthma is simple by comparison to what we're doing, but it illustrates, I hope, the example that this can be done. If we take on this challenge, how are we going to do it? Well, the patient charities are going to be needed to help us recruit the patients across the whole country. We need the health professions, the scientists, the statisticians, and the clinicians to come together to agree the protocol, get a national protocol, and to start looking at the multi-omics technology platforms attached to these subphenotypes when they're identified. It's all about joining forces and translating the theoretical way of moving this forward into a reality. So my suggestion is that following this meeting, and I shall return to this at the end of the conference, is that we need to have a workshop of key stakeholders, not necessarily out of the chronic fatigue syndrome ME field, but out of other fields who are used to doing this sort of analytical approach. Bring them together for a couple of days and to start beginning to agree a protocol, and then approach our funders and start beginning to do what really NIH, also wish to do. But we here in the United Kingdom have the National Health Service. We have wonderful patient charities who are joined up. We can actually deliver on this, I think, if we put our minds to it. And this is going to mean putting aside personal ambition here and looking at the whole effort as a national effort, where everybody is going to gain if we do it properly. So that's really my introduction. As I say, I will return to this at the end of the conference, and I'll be interested in having your views, not necessarily now, but during the next 2 days, as we start to think about whether this is possible, and if so, how we move to this next platform. Okay. So the next bit really is for me to really start the meeting off in a sort of formal way by welcoming our guest speaker this morning, Jose Montoya, who's had the most amazing journey from the west coast of the United States. It is a miracle that he's here, because it is a very long journey with plane delays and train delays and whatever. But you are here, Jose, and I'm absolutely thrilled that you've been able to join us. Of course, you're going to talk about chronic fatigue syndrome and ME and various exciting pieces of work that you're doing at Stanford. But I know that your own work's in infectious disease, in toxoplasma and other related conditions. So it's not as if you're studying this out of the context of other conditions. Indeed, infection has been your driver to get into the field. So we're very, very pleased to welcome you, and we look forward to hearing what you have to say.
Thank you, Professor Holgate. It's a pleasure to be in the UK. And want to share with you what we have been doing at Stanford on ME CFS. And as Professor Holgate pointed, my training really is in formal infectious diseases. And my passion was attracted to this illness. It was easy to fall in love with the fascination that there is something major, big here that needs to be discovered and addressed. And I have been fortunate to attract many other faculty and collaborators at Stanford towards that path of attempting to unveil the pathogenesis of ME. So we are very excited at Stanford and want to share with you, and I want to say in public so that hopefully other universities and hospitals and medical schools follow. But my dean, the medical school, the Stanford Hospital CEO, and the university in large support and believe that this is a field worthy of funding and worthy of pursuing. First, I want to make, if you allow me, 1 minute of silence in memory of Dr. Martin Lerner, a giant in this field, chronic fatigue syndrome. He passed away October 5th, 2015, so please allow me. Dr. Lerner, as many of you know, was one of the few brave physicians who not only believed in CFS, but also treated patients, many patients with CFS, and successfully brought many of them to levels of good function. So I have a wish and a dream, and I think that that wish and a dream possibly could be fulfilled within our lifetime. And it's that I look forward to the day medical and research societies in the United States, and I hope other countries, will formally apologize to CFS ME patients. They have been ignored, ostracized, and humiliated by the very same establishment that was supposed to help them in the first place. And I think that that may not be that far from reality, given what Dr. Holgate mentioned, that the Institute of Medicine came up with a formal report earlier this year establishing that ME/CFS is not a psychological illness. And by the way, when we say it's not a psychological illness, I hope that we don't mean to say that psychological illnesses are bad or that they also be stigmatized. It's just a separate nature of illnesses. And that it's not psychological means psychological treatment will not just do it, will not just help ME/CFS. But there is nothing wrong in having a psychological illness. It's just that the ME/CFS was wrongly, in a misleading way, classified in the wrong box. And just a couple of points of how serious is the Institute of Medicine. Dr. Holgate pointed to this already. It's part of the National Academy of Sciences. This is a private foundation. This is not a government organization. It's non-profit. And they have the best scholars and scientists in the United States that are moving science forward, not only science but also engineering, and dedicated to make sure that the best of science and technology is applied to general good. And it was established in 1863 as a National Academy of Sciences. About 100 years later, the Institute of Medicine was created as part of the National Academy of Sciences with the aim of making sure that only scholars and best scientists will advise the government in policy matters regarding to health issues. So the Institute of Medicine advises the federal government, and they can take tasks or themes on their own. So it's a very serious body, and it's for example, at Stanford, it's an honor to be a member of the National Academy of Sciences or Institute of Medicine. So these bodies are above our best universities. It's the highest level of rank that you can get in science and medicine. So these bodies actually came out and said that ME/CFS is a real illness. These are the committee members, and as you can see, Dr. Martin Lerner was a member of this body. They reviewed about 9,000 articles after they had an initial body of 25,000. They excluded obviously the duplicates, and they end up with 9,000 solid reports pertaining to ME/CFS. And after reviewing all this, they came out to the conclusion, and also they knew as a background that many healthcare providers still mistake ME/CFS as a mental health condition, and many think that is a product of patients' imagination. All these misconceptions have made obviously very hard for patients to get the right diagnosis, and it has been a long history of frustrations. So it's important they stress that ME/CFS be viewed as a serious illness worthy of research and studies. I will not dwell on this definition that Dr. Holgate already put up there in his slides, only to say that remains the core, obviously the fatigue, that has to be more than 6 months, since there is a good number of patients whose occupational, educational, social, personal lives are affected after, for example, an acute infection, yet they can recover within 6 months. But those who go beyond 6 months are likely or could be candidates for developing or ongoing ME/CFS. The other two major components that they identified was the TEM and the unrefreshing sleep, plus either cognitive impairment or orthostatic intolerance. At a study that we are in the process of reviewing, as usual, when I send a paper on toxoplasmosis, I almost get comments and, do this, do that, and then I get it published. When I send myself a paper on ME/CFS, I usually get no, we are not interested, etc. Anyway, that will change. So we have a paper in process where we have compared the definitions, the Fukuda CDC definition with the Canadian criteria and with the SAID definition, and the concordance level is like 90–95%. Especially if you adjust for severity. So the patients who meet Fukuda, severe cases, especially if they had the brain fog at the PM, and the patients who meet Canadian, they more than 90% have concordance with this definition that is simpler. The other exercise that I'm doing in my clinic is every patient that I see with ME/CFS, I apply this definition, and I haven't seen one that does not meet it. So it seems like this group is something really clever and nice and thoughtful in the way that it really simplifies the diagnosis. For Fukuda, remember, you have to have the fatigue plus 4 of 8 criteria. And the Canadian is even worse. You have all these criteria. I don't mean by worse meaning bad, ill-intention. I just say more complicated for the practicing physicians. This seems to really nicely fit the bill for the practicing PC clinician. It's something that obviously we will have hopefully soon that publication accepted where we show that there is a high level of concordance, and we look forward other centers doing the same thing to make sure that this really does the job for what we want to at the clinical level. Quickly and briefly, allow me to give you an example of a patient that is not uncommonly seen in our ME/CFS clinic, and it's just to give you the flavor that the patients that you see, I'm sure, is not different than the patients that we see there. So that what we are facing is the same beast, the same animal, the same disease. It's just that it has a different flavor, different country, different name, but it's the same problem. This happens to be a 47-year-old man who presented to the Stanford Infectious Diseases Clinic because he had been fatigued for 19 years. He had led a healthy and happy life, couldn't be better, the sky was the limit, family, sports, he had degrees from Harvard, from Stanford, an MBA, and he had co-founded several successful companies. At the age of 28, he came down with a severe flu-like illness, and interesting because his business partner came exactly with the same illness, but he, the patient, goes on into ME/CFS for 19 years, whereas his partner goes back to normal life and business life. The patient's flu-like symptoms never went away, and for the following 19 years, he had to stay in bed most of the time. He gave up, obviously, his family life, his sports, and obviously running his businesses. Any minimal activity, even just getting out of bed and moving around the house, was a nightmare for him. And I think that patients can relate to that. So this is a United States citizen, an American patient, top solid citizen, the ones that are responsible for making the United States what the United States is. In addition to the fatigue, the brain fog, the muscle pain, joint pain, unrefreshing sleep, PM, and he could only do 10 to 30% of what he used to be able to do. And remarkably, his physical exam and every possible imaginable test that you could have done in the US was negative. It is very common in the US that when someone has a trouble in diagnosing anything and they have means to pay, they go to Mayo Clinic and they spend $30,000 to $40,000, about 20,000 euros or something like that in pounds for having their whole check, the whole health check, and making sure that something has not been missed. And many of our patients go through that, and when they come back, they always come empty-handed. They don't know what they have. And we are making progress because now Mayo Clinic, at least some of the Mayo Clinic members, are telling our patients, well, you do have ME/CFS, whereas before they were told you have nothing, or we don't know what you have. So that's improving. So this patient went through the usual shop of 10, 20 physicians to be told that either he has something psychological or that he had ME/CFS. And this actually goes back to the late 1800s. So there is at least hints in William Osler's treatise of medicine that back in those late 1800s there was something similar to chronic fatigue syndrome. At that time there was no better term such as neurasthenia, and it has been misinterpreted as psychological, but it took the names of vapors, chronic brucellosis, chronic EBV infection, post-viral fatigue, chronic fatigue syndrome, and you can see Osler's descriptions as a physical inability to reach high grade and the patient may be confined to bed. The patients are usually low-spirited and despondent. Women are frequently emotional. By the way, this is not by no means psychological in nature. Is we believe part of the area of the brain that is compromised by the illness. We have good suggestions that the limbic system is involved in CFS, and the limbic system is responsible for the part of the emotions that we as humans carry, and that's probably part of the disease process. The other thing that he identified that there were subtypes of disease. There was a disease that was cerebral, meaning CNS, spinal, the myalgic, the myelo component, cardiovascular, gastric, and there was another form of patients complaining of everything, but nothing could be found. There was nothing objective, and sleep was significantly involved. So it looks like there were hints that we as a human race have been affected by this illness for hundreds of years, but it looks like we have more focus on the early 80s. Going back to our patient was found to have these high titers against HSV6, the Epstein-Barr BCA, and the early antigen. There were no other explanations for his illness. The titers were, in our view, and in my experience in diagnosing chronic infections such as toxoplasmosis, and I've been fortunate to follow patients infected with this parasite for 30, 40 years. And I know the titers in a chronic intracellular pathogen are always low in the chronic phase. So for me, it was very unusual to see someone who probably was infected with HSV6 when he was 3 years of age, and with EBV around college years, 18, 20. It was very unusual that at the age of 47, he would have such a high titers. And then I also had the experience, and I still do, that I treat patients with infections who have heart and bone marrow transplant patients at Stanford. So that's part of my active practice. And so it was very easy for me to take those antivirals that we use in this patient population and then use it in this patient. And we gave him valganciclovir orally for 9 months, and he had a dramatic recovery after 19 years of unrelenting illness, and he went back to his usual full family life, including physical activity. Since then, we have noticed few other good stories like this. However, we do know that there is a group of patients who do not respond to valganciclovir, and it obviously is a source of inspiration to us to see why. And I'll show you what we believe the valganciclovir does. And it's very exciting because in many things at Stanford it's easy to collaborate with other scientists. And I just ran into another professor at Stanford working on valganciclovir for a completely different reason. And he has found something very exciting that I'll share with you in a few minutes. By the way, I don't have any commercial interest in the manufacture of valganciclovir, not in any of the aspects that we are working on this disease. We have decided to remain clean and independent. So CFS, as I mentioned to you, there were hints that in the late 1800s there was something there affecting us as a human race, and that we were seeing these patients, but really took central attention when there was this outbreak of CFS-ME in the United States, reported in the 80s in the Annals of Internal Medicine, in an outbreak of this illness in the Incline Village in Nevada, in the western part of the United States. If you recall, right there in the early 80s, when ME/CFS gained national attention, there was another epidemic unfolding. Early 80s, exactly. HIV, AIDS. So I think that part of the reason ME/CFS went to a different box of attention, and I'm not trying to justify what was done by the NIH and the CDC, is because the focus went to this other illness, a viral illness that was not known to be viral at the beginning. In fact, at the beginning, there were groups in the United States who thought that AIDS was a punishment from God, punishing men who had sex with men, and then later on it was found that it was the AIDS virus. So as the AIDS virus were really ravaging the United States, and then it was found to be in other European countries and Africa, so I think that the whole attention went to that group, and attention was not given to any CFS for that reason. I think that it should have been given to, obviously, attention to both, but it's part of what happened. And it's no question now that CFS is real, and it affects anyone regardless of racial, ethnic, or socioeconomic background. And I like Professor Holgate's point that towards a personalized medicine approach, we need to make sure that it applies to all members of our society. Most patients are in those years, but we know the ME/CFS tragic onset in the very young. So in my practice, we cannot see patients below age 14 simply because my practice is not pediatric, but we know that is happening at those early ages. Some patients spontaneously improve, but it's usually those in the very early stages of the illness. It's rare to have a spontaneous improvement, let's say after 5 years or after 1 year. And they come in so many different flavors, and that is part of the challenge with this illness, because it means that when one approaches the illness, one brings the biases of one's own training, and everyone will try to see the illness from their own angle. And there is no surprise why many have proposed that it's primarily neurological, cardiac, psychiatric, and so forth. And to make it worse, the patients don't die directly from ME/CFS, per se. They do have a higher risk of lymphoma and cancer, and there is an element of suicide that is highly worrisome, but they stay with the same illness that fluctuates for years, and they have different presentations. So some patients will have more profound GI, others will have more profound cardiac. So making it difficult for someone who has not been alerted to this issue to believe that it's either psychological or there are different illnesses. So how is that Stanford got into something? This is a picture in the 1890s when Stanford just had been opened. How is that an institution like this got involved in chronic fatigue syndrome? And like Dr. Holgate pointed, my training is really infectious diseases. My initial passions, and they remain so, has been toxoplasmosis and infections in transplant patients, but I just couldn't see passing this fascinating disease. And more than that, it was when we had patients coming to our clinic and seeing their suffering, seeing their pain, seeing that they were having a real illness and nobody was paying attention, and that there was a possibility of an infectious disease behind. So we decided to get into it. We saw that there was too much mystery in the illness, that it was very obvious to us. It was very obvious to us that it was real. That came so easy to see patients who were solid citizens going through so much for so long. There is no way that someone, even with good acting skills, could pretend that they were ill when they were not. And then we have always thought, and I still do, and I would love to have questions on this area, that we could still find a single infectious trigger and perpetuator. Obviously, the immediate question I'm going to say, well, how do you say that if there are patients with EBV who clearly can go into chronic fatigue syndrome? There are patients with Q fever who have been clearly documented to do the same thing, brucella and so forth for other infectious agents. And I do have a way to, a hypothetical model to address that. So Stanford involvement in ME/CFS evolved from a very timid attempt, very shy attempt to see few patients in the ID clinic. The members of my ID clinic staff were panicking when I was accepting these patients, because if you have a patient with histoplasmosis or tuberculosis or toxoplasmosis, you see them in 30 minutes and you know what to do. And if it's a follow-up, 5 minutes. But ME/CFS patients, hours if it's a new one, and more than half hour if it's a follow-up. So they were panicking. But we started to see few patients, and it went from that to a whole initiative of collaboration, innovation, and discovering. We made the observation that perhaps patients with herpes viruses could be treated with long-term antivirals, and that could result in some improvement. We went ahead and did a randomized, double-blind, placebo-controlled clinical trial. I trained under a professor, Jack Remington, who's a giant in infectious diseases in the United States and worldwide. He's very tough and very strict, and I'm happy that I was under his tutelage. And I went very excited. We still have lunches with him. I have lunch with him every few weeks, even 20 years after being trained with him. And I was very excited about this. I said, Jack, I found this group of patients, they have UK CFS, I'm giving them this drug, valacyclovir, and they're getting better. And he, with his usual ways of being tough, looks at me back and says, well, you might just as well give them some sugar pill, and they will also get better. And so I took that very seriously. I said, Jack, yes, I'm going to do a double-blind placebo control where half of the group of patients will get the drug and the other one will get sugar pill that looks like Valsai, and that was the origin of that study that I'll show you. The other elements that allow us to flourish at Stanford with this initiative is that there was an anonymous donation of $5 million to our group about 5 years ago. And I only bring this sum here not to brag about it, but just to tell you that $5 million that was given to our group to establish multi-collaboration and multidisciplinary work is the same amount of money the NIH gives for 1 year to the whole United States for UK CFS. So just to see how the numbers don't add up when it comes to NIH funding. And with this, we were able to bring together various disciplines. So remember the elephant where each specialist is trying to come up with their own interpretation? So I thought, let's bring them together. Let's bring immunologists, neurologists, neuroradiologists, psychiatrists, why not? Yes. And it has been really fruitful because he, the psychiatrist, is the main guy in our group who says, how could this be psychiatric? How this could be psychological? No way. The gastroenterologist, cardiology, immunology, pain medicine, general medical disciplines, genetics, bioengineering, and the Human Immune Monitoring Center at Stanford. And so we were able, with this funding, to say, let's have the elephant in the room, but let's have all these specialists looking at the same elephant, but communicating to others what they see from their own strengths. These are our collaborators at Stanford. That includes the Institute for Immunity, Transplantation, and Infection, and the Stanford Human Immune Monitoring Center. So this is a major initiative that came to have concrete standing about 5 years ago. And this was an effort from the School of Medicine at Stanford because we were tired of reporting beautiful findings of the immune system in mice. And mice appear to be different than humans. And so we decided to tackle the studying of the immune system in humans and not in mice. And that's what the whole initiative is about. And obviously we were surprised that there was so much little that it was known of the immune system in humans per se. And we have, because of that collaboration, made a good, serious progress in UK CFS in terms of the immune responses. We have collaborators in the HLA area, neuroradiology, psychiatry. I already mentioned the disciplines that we have. This is obviously the infectious diseases group, neurology, gastroenterology. We also then have approached the illness in various ways, and these are our methods, our scientific study designs. We have the randomized, double-blind, placebo-controlled clinical trial that I alluded to. We have longitudinal studies, that is the brainchild of Dr. Jared Younger, case control studies, and hypothesis-generating studies. In the case control studies, we have a sample size of 200 patients. compared to 400 healthy controls. So this is a biobank. This is the Stanford ME-CFS biobank, where we have done in each of these 600 individuals 51 cytokines on each, inflammatory gene expression, a Cytof, which is a novel way to see the entire immune system in one test. It's like if you were to a huge landscape and with a camera you were taking different shots, and then you take the pictures and you put them together to see the whole landscape. With this, it's taken like a panoramic view, so in one shot you can see the entire immune system. It's a beautiful new test. And then we are working with Dr. Robinson in antibody repertoires. With the Department of Genetics, we have done the HLA in those 600 individuals, and we are working with Ian Letkin. I think Dr. Letkin was a lecturer at this conference last year in pathogen discovery, and we are looking at clinical characteristics of ME-CFS and see how they correlate with each of these. So this is like when you have a beautiful symphony and you have the different instruments, the chords, the wind instruments, and each one has their own part. And that's what we are doing. Each of the different assays is giving us some part of the symphony, but we hope and we aspire to a grand finale. We will have all the pieces being analyzed under one single umbrella, and hopefully that will give us the idea of how in ME-CFS the immune responses are defined compared to controls. Is there a genetic predisposition, and is there a pathogen involved? Because in infectious diseases you always have a pathogen. You cannot have disease in infection if the pathogen does not trigger an immune response. So the reason we get sick in infectious diseases from the flu is not the flu virus eating our tissues and making us suffer. It's the immune response to that virus. So it is an infectious agent that triggers an immune response that makes us sick, and sometimes there is a genetic predisposition that makes some people getting sick and others not. So that is the model underlying, that's the big picture underlying these research efforts. And we partner with this so-called Human Immune Monitoring Center at Stanford that, as I said, has taken the lead in defining the immune system in humans, as this is something that has been done elegantly in mice, but not properly defined in our own race. Because of the nature of what we do, we also have an advisory board, and so this advisory board is made of prominent scientists and professors at Stanford that help to keep the big ship. Remember that we have little, very intense experiments and very devoted aspects of our work, but at the same time we have a vision and that we have a big picture. So this advisory board help us to move the big picture in the right direction. So let's go over a few of the topics that we are moving forward. Sonia, how much time do I have? Sorry? 25 minutes, perfect, thank you. So regardless antiviral treatment, this is the study that misled the entire field. This is the study responsible of why many have thought that there is no role in antiviral treatment in ME-CFS. It was wrong, it misled, and many still cite this study as the reason why antivirals don't have a role in ME-CFS. So it was published in the New England Journal of Medicine by Stephen Strauss. It was using acyclovir for chronic fatigue syndrome, and it was a placebo-controlled trial. There were 27 adults. It was very good design, randomized, double-blind, placebo-controlled. Patients had been sick for about 7 years, and they were screened by persistent antibodies to EBV early antigens or undetectable levels to the EBV NA. They were given IV or oral acyclovir for 7 days, followed by placebo or acyclovir for 30 days. So they got an IV, placebo, or acyclovir for 7 days, and then the oral placebo or the drug for 30 days. Total treatment was 37 days. 37 days. Then they found that out of the 24 patients who completed the trial, similar numbers in the placebo and similar numbers in the acyclovir got some improvement. So neither acyclovir nor clinical improvement correlated with changes in laboratory findings. We conclude, and I'm quoting them, that acyclovir, as used in this study, and they were, good scientists by saying, as used in this study, does not change the symptoms of chronic fatigue syndrome, and we believe that in most changes, it was a spontaneous remission of the syndrome or a placebo effect. And that completely buried the field. That completely made people, then ME CFS is not caused by EBV, and second, acyclovir, and then they expanded it to antiviral treatment does not have a role on this illness. Dr. Lerner actually is the one who deserves the credit, not us. That he went for reasons different than us and started to treat patients with ME CFS with antivirals, getting really better results. So the credit should go to him and not to us. But we observed, as I mentioned to that patient that I illustrated earlier, that patients in whom valganciclovir was used, especially those that had elevated antibodies against the Epstein-Barr virus VCA, EA, and HSV6, they had a significant response in terms of physical functioning. In the x-axis, we have the number of years the patient had been sick before treatment, and you can see all the way to 19 years, all the way to more than 6 months, and then you can see the remarkable improvement that they have when valganciclovir was given. Some of them did have some initial worsening. And we also addressed the issue is duration. So we were giving here 6 months. Remember, the trial was given 37 days. So we have found that if we looked at all the patients in our clinic who had received valganciclovir for this purpose, we found that duration of treatment seems to be important when we see responders versus non-responders. So we believe that if valganciclovir is to be used for patients with chronic fatigue syndrome, it needs to be used for at least 6 months. We believe actually it's 1 year, and in some patients has been 2 to 3 years, with a lot of caveats that I don't have time to go into it, but I'll be happy to answer in the question session. These observational studies led us to then do a randomized, double-blind, placebo-controlled clinical trial that was published in 2000. When was this published? In 2013. And in that study, we found that if you look at the mental fatigue as measured by the MF520, remember that in the MF520, the lower you go, the better you are. We found that patients on the treatment improved their mental fatigue MF520 compared to the ones in the placebo in a statistically significant manner. The same thing happened with the cognitive function that went from this level all the way to this level in the treated group compared to the placebo that practically speaking did not change, and that was statistically significant. We were unlucky that we didn't get a statistical significance with the total MF520, and we believe that part of it is that as patients were getting better, they started to do more and they went ahead and had PEMs, which is something major in doing studies with ME CFS treatment. You have to account for the fact that patients, when they get better, they want to make up for lost time, and they start to do more, and then they get PEM, so it reflects bad on the treatment arm. So it's something that in these partnerships that we want to have with patients, please help us, that when you are in clinical trials and you get better, do not risk PEM. It will make the treatment arm look bad or not look good. The other aspect that we found was that patients on the treatment arm had a drug on their monocytes that we had not, that even the drug company that manufactures valganciclovir had not realized. So in the treatment arm, the monocytes drop significantly. Obviously, there is no drop on the placebo. They're not taking the drug. And this monocytopenia, we believe, is part of why the patients get better. The other aspect was to find that the TH cytokine profile moved from a TH2-like to a TH1 type cytokines. Now, the fascinating thing is that in collaborating at Stanford, the great thing about Stanford is that you find your collaborator and it's one bike ride away. So we are in a beautiful big campus where everything is there, and to collaborate with someone else, you just jump on your bike and you go and meet them. So I met this other professor in neurosciences, Professor Tony Weiss-Corey, who's working on valganciclovir in animal models. And he, on his own entirely, found that valganciclovir is a microglial inhibitor that decreases the activation of microglia, proven in mice where, yes, mice are imperfect to study humans, but in mice you can take brain biopsies and brain tissues and cut the spleens and all that stuff. So he was able to see the brain of mice under valganciclovir, and there is a profound microglial inhibition. And also, he was able to determine that in cells in mice, there is a profound immunomodulatory effect of valganciclovir. So we believe that part of the reason valganciclovir helps a group of patients, it does not help everyone, which is a mystery to us, and we are underway to solve that mystery, is that not only could be putting herpes viruses at rest, not allowing them to replicate, so they are not triggering more inflammation, but also that it is having an immunomodulatory effect in these patients. There is another group of patients that we have worked with, and they are patients who have chromosomally integrated herpes virus. So in all our patients with ME CFS, we measure the HSV6 DNA in blood, and if it's in the order of millions, we confirm that they have a chromosomally integrated virus, and in those patients, 100% of them get better with ME CFS when we treat them antiviral treatment like it was in this patient. In this patient, we documented the improvement by EEG improvement before treatment and then after treatment. And this patient remains fully functional today, despite that she was impaired with the illness for several years. Completely so that she now has a full job and has a child post-antiviral treatment. And now shifting back a little bit to the bigger picture, there has been a lot of immune abnormalities reported in CFS. Part of the problem has been that there have been reports with small sample sizes, and some of them have been contradictory. However, these seem to be the most commonly reported immune abnormalities consistently. And one major one is the NK cell activity being decreased or the NK cells being decreased. And the primary function of NK cells in humans is twofold. It's to fight viruses and to fight tumors. So there is no surprise if one was to find that in ME CFS patients there is an issue in fighting viral infections because of this problem. And also that report that ME CFS patients have a higher rate of lymphoma could also be explained by this low NK cell activity. And herpes viruses are unique because they are everywhere. They infect a significantly large portion of patients, individuals, and they stay for life. So the way we see this is that at least one component in fighting ME CFS is that if we have herpes viruses and they are there for life and you don't have NK cells, the viruses, these herpes viruses could be reactivated because of the lack of the NK cell activity and triggering inflammation. So we believe that there should be a role in ME CFS patients to provide some anti-herpes activity or therapy long-term for that reason. One of the corollaries of this is that we have asked our Stanford world expert on NK cells to work with us, and we are very happy to say that she has agreed to work with us. So we're going to get into what is there in the NK cells of ME CFS patients, why are they low, which ones are low, and what leads to that decreased activity. Next, let's do a brief report in our cytokine studies. And in our cytokine studies, we have used this so-called Luminex technology. Luminex technology allows us to measure 100 things or 100 analytes at the same time. In each bit, you can have an antibody against whatever you want to measure, and that bit is fluoresced by a laser. And then you have another, the analyte that you want to measure, and against the analyte you have an antibody with another tag, with another excitable light. And so when you excite the bead and the marker of what you are measuring, then you can say, I have X or Y, in this case, a cytokine. So it allows to measure a lot of things at the same time. And this allows to measure cytokines on a daily fashion. And this is all the brainchild of Dr. Younger. The credit should go all to him. And what was found was that when you measure cytokines every day in ME CFS patients, and you follow their physical activity, like was it low on that day or was it high on that day, there were 6 cytokines that clearly follow the activity, the daily activity, the daily levels of physical activity. And there was one prominent one, and it was leptin. Leptin tracked the physical activity on a daily basis on these patients. And here we measured 37 cytokines, but leptin was the prominent member tracking the physical activity of the patient. So that was on the longitudinal approach. On the cross-sectional approach, we were able to take all those almost 200 patients, 400 healthy controls, and measures the severity of the illness by MFI-20. And we did a lot of careful, thoughtful, technical corrections to make sure that there was no bias. For example, we mixed the samples from the cases with the controls in the same plate so that we didn't have all the cases in one plate and all the controls in the other plate, and the differences could have been because there were differences in plates. So a lot of thoughtful, careful, detailed attention went to make sure that the differences that we had, if we found differences, were real, and they were not due to technical mistakes. And also we obviously did the average of the duplicate samples, and then we center scaled them to prevent again that we had biases on this. And it's fascinating. So when you take all the cases and all the controls and you compare them, you find that the differences are not as much as you would expect. We measured 51 cytokines in each of those 200 cases and each of those 400 controls. And these were the ones that had statistically significant differences when comparing the levels in both sides. Now, there were these chemokines, CCL5, this ligand for T-cell function, this other chemokine, CXCL5 and CCL5, and they were statistically significant. Now, the statisticians always penalize us because we are comparing too many things. So when they penalize us, they say, the only one after correcting for multiple comparisons that can be statistically significant is CCL5. Though one should always keep this in the back of our minds because they could be playing a role, and it was just because we were measuring too many things that didn't come across. And none of these other ones were found to be significantly different in the two groups. Now, the other ones that were found significant before multiple comparison corrections are here on the left, but when they give us the penalty for comparing too many things, these are the ones that resulted still remain statistically significant. So we are excited about this. Please don't disseminate it in a written form. This has not been published, but we're very excited putting together the publication and send it for publication. However, what we are more excited, even more, is that when we divided the patient into mild disease, moderate disease, and severe disease, and these are the controls. So in this axis, you have controls, mild, moderate, severe. Then it's staggering to see that there is a trend in several cytokines, an upward trend that is statistically significant, and these p-values are after penalization for multiple comparisons. So this is the strongest you can get in any trend that is statistically significant. And look at leptin, the one that was found to be associated on a daily levels in a longitudinal study, coming again significant. So I think that if we would have not done this analysis by dividing the patients by severity, we would have not been able to detect this beautiful trend. And I'll give you an example in something that we see in infectious diseases that is classic. When you have a patient with severe sepsis, the temperature, the fever, some of the patients have very high fever. Some of patients with sepsis have very low temperatures, below normal. And some of patients don't have a temperature. So if I'm given the temperatures of patients with severe sepsis, and I compare them with healthy, I might get similar results because I have ones on the low, some on the middle, and some on the high, and it will become the same. But it's only when I take the sepsis patients and I see the temperature that I will see the trend upwards. And nobody will say, oh, because the temperatures are the same in both groups, you don't have a real illness. And so this is, and I think that the other thing that we see here is the potential. So this establishes, in our view, along with other data, that ME CFS is a highly inflammatory illness. There is a trend of cytokines such as IL-12, interferon gamma, IL-13, leptin, CCF11, GM-CSF, granulocyte macrophage cholestimulating factor is a highly inflammatory cytokine. No wonder why the patients are feeling their bodies inflamed, the flu never going away. There is this inflammation that trends upwards with disease severity. And I think that the stem cell factor is telling us, is whispering us that there must be something in the bone marrow that is putting pressure there, that is making them pump a stem cell factor out in peripheral blood circulation. And these cytokines were measured in blood. And blood goes everywhere. Blood permeates. Blood has to go to the brain and the heart and the GI. It's the way we live. It's the way of life. So we think that this is the main reason that blood, with that inflammation going to each of these organs, the patients had that feeling of highly inflammatory. Sonia, time? 10 minutes. Okay, I want to be responsible for the time. So that's looking at processional approach, looking at with disease severity. So the paper will come with something like a novel signature profile of circulating cytokines correlated with disease severity. And we hope that when studies are done, that disease severity be looked at, because we think that part of the reason we have not found big differences in the studies is that we are not correcting for disease severity. And again, it's the same illness whispering us that it's secrets that we need to have our ears closed to the illness. This is another study that we did with Ian Lifkin, where we look at also cytokines. This case was in plasma, and looking at disease duration. The bottom line here is that when we compare patients who have ME CFS less than 3 years compared to those who have more than 3 years, and these are healthy controls, patients who have less than 3 years appear to have higher level of cytokines when compared to those with more than 3 years. And there was a similar problem that if you just took the two groups, healthy and patients, and you compare them, almost no differences. But then you see something happening when you see duration as the analysis. So either severity or duration has to be taken into account when analyzing this data. We plan to do the same analysis in our cohort. I was part of this study, but the statistical support that I have is very good. So we are planning to do a similar analysis with our cytokines, and more to follow in our publications. Another area that is very exciting for us, and this was one of those areas where I asked the neuroradiology team at Stanford, do you want to partner with me in something exciting, or do you want to keep working in your same boring strokes and stuff? And the guy said, why not? I know you from your other things. I don't know why you're doing this. You are wasting your time. Let's do it. So we got into this not knowing that we were going to have what we found. And this was a diffusion tensor imaging study. This technique looks at the molecular movement of water, the Brownian molecular shifting of water molecules in the brain. And by that, they can then put that into a software that will reproduce bundles, fibers that connect one area of the brain with the other. And because it was an initial study, we went for a really dangerously low sample size. We are very lucky that we got what we got, because we only have 15 patients and 14 healthy controls. And they had been sick for about 12 years. And their MFI-20 that helped us with severity was pretty much in the severe side, around 79. Whereas the healthy controls, as expected, they have an MFI-20 around 27. To be alive, you need an MFI-20 of 20. And then after that, you are healthy if you are below 40 or 45. So the first thing that came, and I'm looking forward to the MRI studies that we presented at this conference. I'm looking forward to see those results. But the first thing that we found was that the white matter in patients with ME/CFS in this study was smaller than in patients in healthy controls. The fascinating thing is that supratentorial white matter being decreasing in CFS patients correlated with the MFI-20. So the more severe the illness, the worse was the reduction in white matter. There was also a trend for the matter in the thalamus to be decreased in patients, but we were penalized statistically, so we cannot claim that was seen in this patient population. The other fascinating finding was that cortical thickness in certain areas of the brain, for example, in the occipital area, in the precentral area, and also in the middle temporal area, they were thickened. The gray matter was thicker in those areas in patients with CFS compared to controls when corrected by age. So there was something in those gray matter areas that was happening in terms of thickness. But what made us even more excited was that when you look at these structures, fibers, bundles that connect one areas of the brain, for example, the right outward fasciculus that connect the temporal parietal area with the frontal area, the right outward fasciculus, and to some degree the inferior longitudinal fasciculus, they were thicker in patients with ME/CFS. And because this technology had not been applied to ME/CFS, we had not seen it. And so another important point in moving ME/CFS is, like Professor Holgate mentioned, we need, in a smart way, apply new technology that had not been applied with the proper methodology to ME/CFS. So that has led us to postulate that it is possible the right outward fasciculus seen here in blue, this is the occipital, this is where the neck is, this is where the nose is, this is the neck, this is the nose. You can see here that the right outward fasciculus that goes from the back to the front, is thicker in patients with ME/CFS than controls. And the same applies to the inferior longitudinal fasciculus going from the back to the front. And it's fascinating because remember that I told you that there were gray areas, gray matter areas that were thickened? Precisely are the areas that the fasciculus are touching the cortex. So we're very excited about that. And lastly, so we have sent a grant to the NIH to expand the sample size and prove that this is the case. Like in anything in science, we don't know what is going to happen. We hope to be proven right, but obviously we have to be open, and we will be validating that study. The last slide that I want to bring to you regarding the inflammation. In that study that we're doing with Ian Lipkin, trying to find if there is a pathogen in peripheral blood that is triggering the illness, he and I found that these viruses that are so-called Torquay viruses or adenoviruses, in fact, are lower in cases than in controls in a statistically significant fashion. And you could be disappointed, and I could be disappointed thinking, well, you have less viruses in peripheral blood of ME/CFS patients. You have been telling us all along that you think that is an infectious agent, that there is inflammation. Well, it turns out to be fascinating. When you analyze these viruses called amyloviruses or tortiviruses in transplant patients and in AIDS patients, the more immunosuppressed they are, the more these viruses are present. Just remember that. The more immunosuppressed they are, the more these viruses are present. In ME/CFS patients, those viruses are decreased, suggesting that their immune system is overactivated. Because in the transplant patients, we did a study, so we took heart transplant patients and we looked at these viruses after transplantation. And in those patients, the longer you have the transplant, the more immunosuppressed you have to be so you don't reject the organ. Those viruses went up. In AIDS patients, the more ill they are, the viruses are active. So the less immune system they have, the more these viruses are present. And in ME/CFS patients, they are lower, suggesting that there is an inflammation that is high in these patients, making this group population of viruses lower. So we are very fascinated by that. So lastly, I think that for the past 33, now 35 years, well-conducted research has clearly provided evidence that ME/CFS is real and that it triggers, perhaps by an infectious process, to a neuroinflammatory process. There are clearly sudden infectious onsets. It looks like it's linked to a chronic activation of the immune system supported by the data that I presented to you. There are a lot of groups that have shown that there is HPA axis abnormalities. All these significant cognitive difficulties are not due to psychiatric disorders. There is significant involvement of the autonomic system, and there are plenty of MRIs, PET-EEG abnormalities that have reported by many. Most, if not all, pathogens that have been associated with ME are intracellular, suggesting certain type of immune responses that are associated with these pathogens as compared with the extracellular. In addition to being intracellular, they seem to have a tropism for the respiratory tract and gastrointestinal tract, and from there it's possible that they lead the inflammation to areas of the central nervous system or lymphopoietic system. ME is being validated today, and I agree with Dr. Holgate's last comment. I think we are about to turn the corner as a real and highly inflammatory illness with significant brain involvement. And it's through multidisciplinary efforts and that we will be able to finally make possible that dream one day where we will be able to report what exactly ME/CFS is. Thank you.
Well, ladies and gentlemen, I think we'll have to agree that this was a really spectacular introduction to our two-day conference. And remember, he's only just come in from California, so he's done a great job. I'm going to give him 5 minutes, 10 minutes, half an hour to sit down and rest for a moment, because we've got two other presentations, because it'd be quite nice to have these presentations discussed in the context of your talk, Jose. So thank you so much for that wonderful introduction. Please take a little rest for a moment. We'll do the questions in a few moments. So we're going on now to some short presentations by some of our researchers here in the UK, which are directly relevant to some of the discussions you've been hearing from Jose. And we've got Whitney General is going to start from Bristol, and she's going to tell us about neural correlates of fatigue, Voxel-Based Morphometry MRI study in chronic fatigue syndrome. Thank you very much. We need to get your slides up. Thank you.
So I'll be discussing one of the structural MRI imaging projects that we've been doing in Bristol, and I'll briefly go over what voxel-based morphometry is, and past medium studies that have been done in this area, and then I'll discuss the three main findings of our study. So a voxel, by simple definition, is a 3D pixel, and it enables you to get sort of a 3-point coordinate, so it's very handy. Yeah. It's very handy in sort of analyzing the brain in 3D. So essentially, we use voxel-based morphometry, which is a neuroimaging analysis technique that allows you to sort of investigate the brain and look at focal structural differences in the brain, so you get a specific idea of where you're looking at and where the differences are. And we use a statistical method called SPM, which stands for Statistical Parametric Mapping. And there's two ways to look at structural differences. You can look at it globally or regionally. So globally, you can sort of make overall comparisons and say overall there's a decrease or increase in gray matter density in the brain. Whereas regionally, it allows you to locate specific regions within a lobe in the brain. So you can specifically say this particular lobe, within this region, in that lobe, we found some results. So you can say in that region there's been an increase or decrease in gray matter as well. So we used regional differences for our data. And gray matter is the outer regions of the brain, and that contains the nerve cell bodies. And then the rest of the nerve, which would be the axon, is contained in the white matter, which is of interest in functional MRI studies, because the axons are actually the parts of the nerve that transmit the signal, so you can sort of look at the connections. Our data specifically looked at gray matter. So in terms of past VBM studies, in 2005, Lange et al. Found that there was an overall reduction in gray matter, and he actually had two cohorts. So the red represents the CFS patients, and the green represents the healthy controls. And in both cohorts, there was a reduction in the patient groups when he compared them to the healthy controls. Then in 2004, Okada et al. Found more regional differences, and what he found was that there was a reduction in gray matter bilaterally in the prefrontal cortex, and this was by an amount of 11% when he compared them to the healthy controls. And more recently, in 2012, Curie et al. Found that there was a reduction in both gray and white matter, but in the occipital lobe. And then furthermore, he found that the gray matter was further reduced in the angular gyrus as well as the parahippocampal gyrus, which is of interest as this came up in our findings as well. So our study consisted of 22 CFS patients and 22 age and sex match controls, and all of our participants underwent a high-resolution structural MRI scan in our machine here, which is a 3T MRI scanner at Crick in Bristol. And all the CFS patients underwent a fatigue questionnaire that was done before their scan. And our patients sort of had CFS for an average of 21 months, whereas other studies, their patients sort of had the condition for approximately 10 years, more or less. So to discuss our findings, we had three main findings, the first of which we found increased gray matter density in sort of these regions here. So you can see the green highlighted in these images, and these are coronal slices taken from the side. So you kind of put the brain into a front region in the back portion, and we found increased gray matter locations in various regions around the brain, so in all the lobes of the brain. So this is our first finding. The second finding was rather interesting because we found that the patients had a reduction in gray matter density or volume, if you prefer, specifically in the right posterior parahippocampal gyrus, which is indicated here in the red. And this is just a slice sort of in the sagittal plane, so it divides the brain into a left and right region. And this was when we compared them to the healthy controls. Lastly, we did a multiple regression statistical analysis to see if there was any correlation between the fatigue scores gained by the fatigue questionnaire and the gray matter. And what we found was that there was a positive correlation, but with the right medial parahippocampal gyrus, and this is highlighted in the yellow here. So to summarize our results before we go on to discussing them, the first set is that we had increased gray matter density in the sensory regions and in the frontal lobe for the patients. And secondly, we had decreased gray matter in the posterior parahippocampal gyrus. And lastly, when we compared this to the fatigue scores, there was a positive correlation with the medial parahippocampal gyrus. So just to discuss some tentative thoughts and what we think could be happening to explain these results. So firstly, no previous study reported increased gray matter density in the regions that we found. So we think because our patients on average had CFS for 21 months, this could represent sort of an early stage in the disease where you have hyperactivity, and then the prolonging of this hyperactivity could be responsible for the gray matter atrophy seen later on in the disease, which other studies, as I said, had chronic fatigue patients that who have had the condition for 10 years, because Curie et al. In his study found that there was a reduction in gray matter in the occipital and frontal lobe. Furthermore to that, we think that this area would benefit from longitudinal studies to see if the gray matter is associated with early stages in chronic fatigue, and then a step from that is to see if a reduction in gray matter is associated either with the severity of symptoms or the length of the illness. And secondly, CFS patients have particular problems with working memory, processing speed, response speed, and attention overall. And this, these functions are, the frontal lobe is responsible for these functions. So we think that the increase in gray matter that we found in our study closely relates to the functional MRI studies that find increased activity when their patients sort of undergo memory tasks and other tasks that target these aspects of cognition. So overall, we think the other regions that have been recruited, such as the occipital lobe and the temporal lobe and the parietal lobe, could represent that the patients are recruiting more brain regions in order to increase the level of output so that they can still produce a sufficient amount of signal to function normally. And this links into the theory of sensory gating and sensory overload, where sensory gating functions to not allow the higher cortical centers to sort of be bombarded or overstimulated with redundant or unnecessary information. So if that's impaired, you ultimately can get sensory overload, where the higher cortical centers are bombarded, and we think that this could be happening in the patient group. And to sort of explore the second finding, which was a reduction of gray matter in the posterior hippocampal gyrus, this could be related to memory decline, and other studies outside the field of CFS that looked into age-related memory decline and Alzheimer's disease also found that the posterior parahippocampal gyrus was implicated, and in Alzheimer's disease, this region was particularly smaller in the patient group. And this links back to the finding from Curie et al. In 2012, who found that the posterior parahippocampal gyrus was significantly reduced. And just to sort of finish off and discuss what the future of this field could benefit from is that one, larger sample sizes would be beneficial because you can generate greater statistical power. And secondly, as mentioned, longitudinal studies would be of great interest to see if there's any correlation with the gray matter sort of changes and the symptom severity, as well as for the length of the illness. And it would be great if structural studies, MRI studies, could be used alongside functional MRI studies so that you could get sort of a better picture of what's going on. And lastly, I'd like to thank my supervisor, Dr. Jay Thai, who's here, Dr. Esther Crawley, Ms. Crystal Van Antwerp, Dr. Simon Collin, Dr. Hazel, and for all the participants who participated in the study, as well as our research funders.
What a brilliant study. I mean, isn't that fantastic? You know, really good technology applied to well-characterized patient populations, fascinating findings, a real attempt at interpreting them. So, thank you very much, Whitney. That's great. We will be maybe asking you some questions in a minute. We'll hear Andreas Finkelmeyer's talk next. And Andreas is from Newcastle here, and he's going to talk about brain white matter hyperintensities and chronic fatigue syndrome.
Yeah, good morning, everyone. I'm Andreas Finkelmeyer from Newcastle, so I think we sort of scaled the distance from the farthest to the nearest in these talks this morning. However, I think topically it also fits quite well because, as we just heard about gray matter from the previous speaker, I'll be talking about white matter and specifically about white matter hyperintensities. So what are these? Well, simply they're areas of brain white matter that show abnormally high signal intensities on certain types of MRI scans. So here, two examples. These are two MRI scans of the same individual. On the left is a so-called T1 weighted scan. It's typically used for these types of EBM studies that the previous speaker was talking about. And you know, the sort of white matter, the fiber tracts are sort of in the central area of the brain. There's the gray matter, the cell bodies, also it's gray part here. On the left, we have a so-called T2 weighted scan. These are actually the types of scans that are typically used for looking at white matter hyperintensities. And this particular image, this is a perfectly healthy, well, it was actually one of the patients, but it's a perfectly normal-looking T2 scan. There's nothing remarkable about this. However, if we compare this to this individual here on the right, you can see even someone who's fairly untrained that, oh, there's a couple of things that do look a little bit different, apart from obviously being a different, say, different shape. But you can see relatively clearly that there are some areas where in the white matter we have areas that are particularly bright. So, and these are exactly these types of abnormalities that we're talking about when we speak about white matter hyperintensities. And well, what are they? Well, ultimately they're whiter because there's more water in the tissue, and there are actually a multitude of underlying pathologies that cause these hyperintensities, such as dilated perivascular spaces, perivascular demyelination, and so on and so on. So, and they are actually quite common, and especially as people get older, and a lot of the research that has been done on hyperintensities has been done in the aging field. So there's some that's suggesting that by the age of 80, 85, you'll most likely find these white matter hyperintensity in anyone. Okay. Well, what do they have to do with chronic fatigue syndrome? Well, actually, they've been researched quite a bit and for quite some time. So probably one of the earliest studies in this area was by Angel in 1993, who found higher incidence of these white matter hyperintensities in the CFS group compared to controls. However, it's not quite as sort of clear throughout the years. So we look at a couple of years later, Schwartz et al. Did find the slightly more frequent hyperintensities in the CFS group, but the difference from the controls was not statistically significant. Again, Cope et al. Also didn't find differences between the CFS group and the control group, with actually a tendency for higher incidence for people who had comorbid depression. Greco et al. Also didn't find differences between 4 different groups of CFS patients without psychiatric comorbidities, with depressive comorbidity or other psychiatric comorbidity without the controls. And they've actually found a tendency for more frequent hyperintensities in the group without any psychiatric comorbidities. Among all this same person that was just mentioned, different study, the 99 found high incidence of white matter hyperintensities in the subgroup of CFS patients without depression. Later they showed that there's a relationship to physiological function. But then again, studying more later study again found no difference in CFS patients without depression healthy controls. So there's a bit of a mix of results in terms of findings with white matter hyperintensities. Nonetheless, Nielsen 2 years ago came up with this hypothesis that that a subgroup of patients with CFS has an underlying neurological disease which leads to symptoms of fatigue and cognitive dysfunction. And that has always been sort of a bit of the guiding hypothesis for these white matter hyperintensities, and they are perhaps a manifestation of why people experience cognitive dysfunctions and brain fog that the patients experience. So we decided to look at this as part of a much larger study that was completed in the last couple of years, led by Julia Newton days. And we did several MRI scans with participants, including these two MRI scans. We decided to exclude any patients who had clear comorbid depression or any other psychiatric comorbidity, and try to match our control sample, of course, with regards to age, size, but also in regards to physical activity. We ended up with these two groups. Our CFS group actually pretty substantial size, 41 participants, about 3/4 of them. Mean age of 45, control group, unfortunately only 10, I'll come back to that. About the same age, about the same gender distribution, and as I said, low sort of average physical activity. As I said, we did fairly routine clinical T1, T2 weighted MRI scans of the brain with them. And so in contrast to these earlier studies that I mentioned, we didn't simply look at whether or not an individual participant had evidence of white matter hyperintensities, or a yes or no decision, but rather we decided to actually quantify the amount of tissue that was being affected by these white matter hyperintensities. And we did this with a semi-automated procedure, which basically looked at the intensity and the locality of the image with the voxels and to try to identify these intensities. And that's just an example of what this looks like. So you can see what the algorithms identifies, and you can see more or less clearly identifies some of the intensities they reach, but it also actually managed to find some really small voxels that potentially would have been missed by a human observer who would have to decide whether areas are exhibit hyperintensity. And because we obviously now have a volumetric measure of these intensities, we have to control for the fact that people have different sizes of brains. And as I said earlier, age is a significant factor in what we are hyperintensity. So what did we find? And if you saw the title of the talk earlier or in the program, you probably can guess what's coming. Well, in terms of the group difference, there was none. We didn't find any significant difference between our groups and the amount of volume that was affected by white matter intensities. So on the left we have our control, the CFS group, on the right our control group. You can see they completely overlap, and statistically there's absolutely no difference between the two. The other thing that we actually saw is that, well, the amount of white matter hyperintensities that we find is actually quite low. To give you a bit of an indication, because that's a bit of an abstract way of looking at this being 1,000 cubic millimeters, well, that's 1 millimeter. But perhaps if you give you something more easy to imagine reference, this one here represents 530 cubic millimeters. That's the volume of an object you're very familiar with. That's the volume of a 1 penny coin. But that's how much you can see. Oops. That vast majority of patients and half the controls are well below that volume. So overall, we didn't find a whole lot of evidence for any significant white matter hyperintensities in our patient sample. What we did find, and that was expected, that as people get older, we do see an increase in the volume of hyperintensities, and that is statistically significant finding. But again, that's not at all surprising. That's something we would have expected from the literature. And you can also see in controls of our response here, they look pretty much at 15 patients. Well, nonetheless, we looked at a couple of correlations with various other things. So, for instance, with cognitive functioning, and so on top of all the other assessments that we performed for patients, they did complete a battery of cognitive tests, and out of those, only 2 actually show the hint of a relationship with our hyperintensities. And the first one was the attention network test, specifically the awareness score, which basically is an indication of how much benefit you get from being alerted to oncoming stimulus in terms of reacting to that stimulus. And you can see there's a negative relation basically as well. Increases actually massively and potentially see a slight drop in reaction time. And so that was at least statistically significant at a trend level. The other one that came out was the backwards score of the spatial working memory, so being able to repeat a visually presented sequence of locations backward. Again, found a negative correlation. The more white-matter hyperintensities we see, the less trials participants were able to perform correctly. But again, it looks pretty much identical in both groups. So that doesn't seem to be that same thing that's specific to chronic fatigue syndrome. In sort of 2 measures of more sort of subjective measures of cognitive dysfunction, we didn't see any relation to any cognitive failures questionnaire. There was no relationship to white-matter hyperintensity. And in the cognitive domain of the fatigue index, there also no relationship to white-matter hyperintensities as measured in our study. So in summary, our study at least shows that there's no evidence for increased white-matter hyperintensity in our sample of CFS patients, again, all of which were not depressed. We do see the expected effects due to age, and we do see a few relevant correlations with objective measure correlations with self-reported cognitive difficulties. Of course, a couple of habits, and the first one should be fairly obvious for all. Obviously, the sample of control groups was a really small sample of individuals in this study. And right now, we're trying to potentially identify more healthy controls from other studies, potentially. That's a breed of institutes considered fairly typical. There's nothing special about them, so other studies continue doing as well to boost the numbers a little bit. The other is not quite as obvious, and that is, as I mentioned earlier, the study itself is a really big, large study with lots and lots of assessments. And perhaps what we ended up recruiting was patients who were actually not too unwell, so they were still capable of, or they agreed to participate instead of knowing how much they would have to do, and perhaps that led to us recruiting patients who were not as severely affected. Nonetheless, even looking at other indicators of severity, we didn't see any relationship with our hyperintensities. With that, I want to thank my collaborators and the university for funding the study, and of course all our participants who participated in this and all the other different assessments that we performed in this study.
And again, a very interesting study using technology that's obviously shining a light on this disease. What I thought we would do now is spend 10 minutes just having questions. So maybe we could ask our speakers. Jose, maybe we could ask you to come up, and our 2 presenters as well. And we'll take questions from the floor, and we'll see how long it lasts. I know you're getting hungry, so yeah. Could I, before we go into this, could I also say, you probably noticed my name is not Hugh Perry, because Hugh, unfortunately, is not well. So we'll be sending him a card from here, but I shall only send the card if this meeting is a success. Good, Charles.
I can do without my this is to Jose, who we've met before. Going on to Valsine, I'll answer it. As you're probably aware, here in the UK, we as doctors not allowed to prescribe antiviral drugs due to our what they call nice, so real parasite for? Is it someone who's got raised tetas, suggesting that they've got raised activation rate HV6 and early onset and infective symptoms, or what's your gut feeling as to who you would prescribe this alcohol for?
Thank you for the question. So we have moved away from the patient has to have the very high titers of HSV6 and EBV, VCA, and EBV early antigen to pretty much any CFS patient who had either a viral onset or who has ongoing flu-like symptoms. The other group is those patients who are found HSV6 chromosomally integrated. In the peripheral blood, HSV6 DNA is several million copy numbers in blood. So those patients we have found tend to respond 100%. The patients we have identified HSV6 chromosomally integrated, they all have responded to antiviral therapy. And the groups that do not have, pretty much we try to identify those that have the more inflammatory ongoing symptoms. And then the other thing that we have found is that in addition to prepare the patient for a long intervention, a year, 2 years, 3 years, is to make sure that we don't introduce the high doses that we thought they were important. The only reason we use the high dose in the randomized clinical trial was because the FDA, in order to give me the approval that I will do this study, so I went formally. I did everything as formal as one can do in the US. The FDA asked me to use the same dose that it had been approved for the treatment of CMV in AIDS and transplant patients. And in those patients, we do treat with very high doses for 2-3 weeks, and then we go to half. And so I just borrowed that model that prevented us from doing studies for years before we could do anything in volunteers to come up with a new dose. So the approach, the wise thing to do now is you start with low doses and then you work your way up and then you stay. I would love to see one day that in the UK the drug can be used, but that's another topic.
The only way this is going to be used in this country is to have a trial with 150 patients and a much greater, level of power, really. And I think, you've shown us very tempting experimental medicine studies in a way that says that such a trial needs to be done. And we do have a mechanism for doing this in the UK called the Efficacy and Mechanisms Evaluation, which is supported by the MRC and the NIHR. So there's no reason why a protocol couldn't be put together and submitted to EMI on the basis of these preliminary and other, presumably, data that others have got.
Sorry, can I just say one thing, Steve?
Yeah.
We had a meeting with Roche to try and push forward Roche to do this, and there was no interest in Roche.
But Roche wouldn't need to have to pay for it, though.
Yes.
So this would be EMI would pay for this. So this isn't, because this is getting off patent, I suppose, isn't it, really? So no drug company, unless they really were convinced, would do a study. But so therefore the study has to be done in the public space. And that's why I think it would be possible to do it.
The other thing that I want to warn is that we have also found patients who have very telling clinical phenotypes. For example, patients whose lives are completely normal, they come down with either oral or genital herpes. And they clearly say, when you listen to your patients, you get so much wisdom. They tell you, every time that there is a clinical outbreak of herpes, orally or genital, my symptoms are way much more worse. So what we do in those patients is we focus on suppressing the oral or the genital herpes, and we use doses of either acyclovir, fanciclovir, or valacyclovir, all the way until those lesions are not clinically evident, and then we just 3, 4, 5 years of complete suppression. We realized that to control herpes viruses clinically, you not only need a good antiviral, but a good anti-inflammatory drug. So we are experimenting with other anti-inflammatories, and I would love to one day have a conversation with Dr. Holgate's expertise in pharmacology and in the area of asthma and inflammatory diseases, because that's our next big step, is knowing that there is an inflammation, what are the things that will ameliorate the symptoms if we control the inflammation the same way that we do for rheumatoid arthritis, lupus, not knowing what causes those diseases. Patients get better when we control the inflammation.
Yeah, good point. Okay, more questions. Thank you very much. Yes, sir.
Hello, my name's Lionel Lubitz. I'm from Melbourne, Australia, the Royal Children's Hospital, and I've come here to make some friends.
And you brought your nice weather with you, so thank you very
Thank you.
much. Yes.
And I wanted to just comment on what Whitney was talking about. We have a research program that is currently being actually funded by ME Research UK, thank you very much, where we're looking at the prefrontal cortex of children with chronic fatigue syndrome, because we're pediatricians and we were worried about brain fog. And our findings, which are not yet being published, and was very small numbers as I mentioned to you, are very interesting. We have taken a group of children where we give them a task and we look at their functional MRI before and after, and there are quite significant differences, of course, as you'd expect, between the CFS kids and the controls. We only have 12 kids done so far, but when we've got more, we'll publish it and bring it to this meeting. The second question I wanted to raise was with Dr. Montoya. I will also reassure you that in my hospital 25 years ago, Kathy Rowe and I were the little lone voices at the back. We now have quite a big program, which I'm interested to talk to you about, where we have much more involvement in our hospital and university in chronic fatigue syndrome.
Yeah, well,
That was my comment.
Well, that's very encouraging, and it also suggests that this wonderful new technology of imaging, which you explained to us, which will continue to improve and increase, is giving us tremendous insight into these conditions, which a few years ago we had no chance of understanding. So this is fabulous, absolutely wonderful. And I think what I heard from both presentations was the fact that you were making a real effort to do the structure-functional relationships, because that's really what's important here, isn't it? And you were describing it very nicely in your study in Melbourne too, so it's marvellous. Now then, yes, please, ma'am.
I'd just like to ask all of you, actually, but especially Professor Montoya, how do you include the severely affected? And if you don't, how are you going to make steps to do so?
Well, I can make a quick comment, but I think maybe Julia is the one who would be better commenting on that. And I think Julia has actually a study ongoing at the moment that looks at really severely bedbound individuals, and you're perfectly right. And that was one of the comment. The reason I made the comment at the end that perhaps because of the studies we're doing, we may actually inadvertently exclude a number of people from the research that we really should include.
Yes, I would quite like Professor Montoya to say how severely affected is most severely affected patients.
Right. So echoing Andreas' comment, so the bottom line is we decided to invest, like in any of these days in research. It's not like in the 1990s where you had an idea, you do the experiment, and if there were some good data, then you will get money to pursue further. Now you have to have the money before even you get a pile of preliminary data. Anyway, so what we plan to is to invest on getting a car going to the patient's home. They cannot be even sitting, they cannot sit up, patients even less stand up. So we plan to have the transportation cannot be on a regular car. There has to be an ambulance that are in a stretcher and bring the patients to the facility and just have the MRI, for example, ready. So they go in, they get the study, and they get out. Versus they go in, they sit, they wait, and then the other thing is that we have, luckily the Department of Neuroradiology has a cool state-of-the-art MRI just for research. So you don't have to use the hospital, like if a trauma comes, then it pumps any research. So we realized that we are short in reaching out to those patients. The other thing is we got the IRB to approve that we can get the blood drawn in their houses. And that's in the US has a whole set of legal implications. And so we were able to overcome those hurdles. And so we'll be getting the blood drawn there, the questionnaires there, and for things like the MRI that 2015, we cannot take to the house yet, we need to bring the patient and we'll do it through the ambulance and so that the patients have minimum. But that's a huge problem. And I have had the privilege to go to some of the patients' houses, and it's painful to see them in bed, not being able to move. And it's real. Even a small light of light that comes through the curtains makes it painful for them. So what they experience is real. So yes, that's our plan, but it's not easy.
Thank you. And again, technology may in future give us portable ways of getting access non-invasively, and that of course will transform the area. And we're seeing increasingly the use of technology now at the engineering side of things, not at the pharmaceutical and biotechnology side, but at engineering, being developed all the time. So, and I think, not only in that, but in diseases like dementia, where ambulatory and other forms of monitoring in the home and in the community are becoming increasingly used now. And we might be able to learn quite a bit from those technologies, which we haven't brought into this field yet, properly. I think the other thing that came through in both of these presentations was actually the wide variation that occurs in the imaging. I mean, you're not talking about a small cluster of, points that are all close together. I mean, there's huge inter-individual variation, even in the normal volunteers, let alone the disease ones. And one's talking about looking for a signal within quite a noisy sort of field. Really. The fact you're able to find anything is amazing, obviously. So, please, yes, sir.
I've got a question for Andreas.
Yes, Richard.
I work in the field of multiple sclerosis, and as you probably know, fatigue is a major problem with MS, and has many similarities to what we're talking about here. And there's an idea in MS research that the fatigue may have a more diffuse origin within the central nervous system rather than a focal one. So have you looked at any other kind of signals that might show up as a more kind of diffuse process within the brain?
We have looked at just perfusion, so brain blood diffusion in brain white matter. Haven't really had time to look at that super closely, but there is a poster out there on some aspect of that related to orthostatic intolerance and brain perfusion. But in sort of truly distributed diffuse changes, not yet, no. I think that would be interesting with some other scans one could do. Probably look at changes in resting state, fMRI data, and network characteristics. Pretty sophisticated maths models behind that, so that might be interesting to do, but we haven't done so.
We need to get the MS field more involved in this area. I mean, there are some fabulous scientists across the world who are working in your area, and we somehow need to engage with that community more effectively.
There was a workshop organised by the MS Society, and it must now be about 10 years ago, getting together some big work in fatigue syndrome and MS, and nothing happened afterwards, unfortunately. So, yes, we do need to.
I think the time is coming when this needs to be revisited with the new technologies that we've been seeing today and we'll be seeing later. Yes, sir.
I've got a question for. I've got a question for Professor Montoya. I wanted to comment a little bit more about the NK cell work that he's proposed to do, and I'm just wondering whether they may, rather than have a cytotoxic defect, be more immunoregulatory defect.
Yes, so we realized, as I mentioned, that it's a commonly cited issue, defect, problem in ME CFS. And we think that we want to approach it from a more systematic, fundamental way in various aspects. One, it turns out to be that NK cell as such doesn't exist. In other words, NK cell like many thousand types of NK cells. And so when you look at that, it's like, how could we ever